The treatment options for carpal tunnel syndrome may be non-surgical and surgical. Non-surgical treatment may be for patients with mild to moderate carpal tunnel syndrome. It is useful when there is no muscle weakness or atrophy, absent denervation or nerve supply is intact, and mild abnormality on nerve conduction studies. Pregnant women with carpal tunnel syndrome rarely require surgery as symptoms resolve spontaneously. Non-surgical treatment includes activity avoidance, use of a hand brace, splinting of the wrist, oral steroids, local injection of corticosteroids, non-steroidal anti-inflammatory drugs, oral vitamin B6, ultrasound and laser therapy, workplace modifications, exercise, and yoga. Out of these, steroid injection is the most successful treatment, though it may cause symptoms to worsen temporarily, but can produce complete or significant pain relief for 60 to 70% of patients for weeks to years. Surgical treatment is reserved for patients with moderate to severe symptoms of carpal tunnel syndrome for whom conservative treatment has failed. These patients experience subjective weakness, clumsiness, severe numbness, thenar muscle atrophy or muscle wasting, and severe loss of dexterity. A strong indication for carpal tunnel release is muscular atrophy or wasting. The surgical procedure consists of releasing the transverse carpal ligament. This releases the pressure over the compressed median nerve and increases the space in the carpal tunnel. There are two different types of surgical approaches: open and endoscopic release. Open carpal tunnel release is not to be confused with the mini-open technique described next. The procedure uses a 4 to 5 centimeter longitudinal incision as seen here. This incision opens a substantial amount of tissue through the skin and underlying layers down to the transverse carpal ligament. Remember, this is the ligament that must be cut to relieve pressure from over the compressed median nerve. The overall success of open carpal tunnel release ranges between 75 to 90%, while recurrence has been reported in 4 to 57% of the cases. There have been several modifications to the length, location, and shape of the incision in open carpal tunnel release. The most common modification is the mini-open release. This technique uses a 2 to 2.5 centimeter longitudinal incision to release the transverse carpal ligament under direct visualization. The view is actually somewhat limited for the surgeon during the surgery due to the smaller mini incision. Besides open techniques, there are several endoscopic approaches with the same underlying principle to release the transverse carpal ligament. There are less invasive techniques to facilitate earlier return to work for the patient with less pain and scarring. Endoscopic carpal tunnel release techniques can be divided into single portal and two portal techniques. The two most commonly used techniques are the single portal technique, described by Dr. A.G. in the early 90s, and the two portal technique described by Dr. Chow in the late 80s, both still used today. The single portal technique makes use of a small 1 centimeter transverse incision at the palm crease to insert a device that transects the transverse carpal ligament by pulling back in a single motion. The two portal technique uses the same 1 centimeter palm crease incision along with a mid-palmar incision as well to gain access to the carpal canal. Several studies comparing endoscopic and open techniques found that endoscopic carpal tunnel release was associated with reduced scar tenderness, an increase in pinch grip and pinch strength by 12 weeks after surgery.